Aicardi-Goutières syndrome, AGS, is a rare genetic disorder that primarily affects the brain, immune system, and skin. It is typically characterized by early onset encephalopathy, leading to developmental delays, spasticity, and progressive neurological deterioration. The syndrome mimics a congenital viral infection in its presentation, even though no infection is present. Key features include neurological symptoms, developmental delay, spasticity, irritability, seizures, and white matter abnormalities on brain imaging, leukoencephalopathy. Skin abnormalities, chilblain-like lesions, particularly on the fingers, toes, ears, and face. Autoimmunity, inflammatory responses that damage tissues, leading to interferon-related conditions, interferonopathy. It is caused by mutations in any one of several genes, e.g., TREX1, RNAH2A, RNase2B, etc., which are involved in DNA repair and immune regulation. AGS can be inherited in an autosomal recessive or, less commonly, autosomal dominant pattern, depending on the gene involved. There is no cure for AGS, and treatment is mainly supportive and focused on managing symptoms. The diagnosis, follow-up, and treatment of Aicardi-Goutières syndrome, AGS, require a multidisciplinary approach, given its complex neurological and immunological features. Here are the main guidelines for each stage. 1. Diagnosis. The diagnosis of AGS is primarily clinical, supported by genetic testing and neuroimaging. Clinical presentation. Early developmental regression in infants or young children, often before 1 year of age. Spasticity, seizures, and progressive neurological symptoms. Presence of chilblain-like skin lesions, often during cold weather. Elevated levels of interferon alpha, IFNA, in cerebrospinal fluid, CSF. Neuroimaging. MRI of the brain shows calcifications in the basal ganglia, white matter abnormalities, leukoencephalopathy, and cerebral atrophy. Laboratory findings. CSF analysis, raised levels of IFNI, neopterin, and other markers of immune activation. Blood tests often show a chronic inflammatory response with elevated inflammatory markers. Genetic testing, mutations in genes such as TREX1, HASH2A, RNase2B, SAMB, or others confirm the diagnosis. Differential diagnosis. AGS mimics congenital infections like torch, toxoplasmosis, other syphilis, rubella, cytomegalovirus, herpes simplex syndrome, other interferonopathies, and neuroinflammatory disorders. 2. Follow-up. Ongoing monitoring is necessary due to the progressive nature of AGS. Neurological monitoring. Regular neurological exams to assess motor function, cognitive development, and seizure control. MRI follow-up. Periodic imaging to track the progression of brain calcifications and atrophy. Immune system monitoring. Blood work, monitoring for chronic inflammation markers and autoimmune signs. Developmental and cognitive assessments. Developmental milestones track growth, motor skills, and intellectual development. Cognitive evaluations. Regular assessments to plan for interventions like speech therapy, physical therapy, or occupational therapy. Skin monitoring. Monitor for recurrent or worsening chilblain lesions and skin ulcers, especially in colder climates. Treatment. Treatment is symptomatic and supportive, as no curative therapy exists for AGS. Management focuses on alleviating the disease's effects on the nervous system, skin, and immune system. Neurological symptoms, antispasmodics to manage spasticity, e.g. baclofen, botulinum toxin, anti-epileptic drugs for seizure control, physical and occupational therapy to maintain motor skills and mobility. Assistive devices, wheelchairs, walkers, or braces may be necessary as the disease progresses. Immune system modulation, immunosuppressive drugs. Some patients may benefit from corticosteroids or other immunosuppressants, e.g. hydroxychloroquine, mycophenolate, to dampen immune overactivity, though efficacy is variable. Skin lesions, topical treatments, moisturizers, and wound care for skin lesions. In severe cases, systemic immunosuppressive agents may be considered. Emerging therapies, interferon-blocking therapies. Since AGS involves abnormal interferon activation, drugs targeting interferon signaling, e.g. Janus kinase JAK inhibitors, are being studied in clinical trials and may show promise. Supportive care, speech therapy, to support communication development. Nutritional support. Some children may require feeding tubes due to difficulty swallowing. Psychological support for the child and family, as dealing with a chronic and severe illness can be emotionally challenging. 4. Future considerations. Gene therapy. Research into gene therapies targeting the genetic mutations in AGS is ongoing but not yet available. Clinical trials. Families may be offered participation in studies aimed at developing targeted therapies for interferonopathies like AGS. 5. Prognosis. The prognosis of AGS varies depending on the specific genetic mutation and severity of symptoms. Generally, the disease is progressive, leading to significant neurological impairment. However, life expectancy and quality of life can be optimized with early and comprehensive multidisciplinary care. Yes, Aicardi-Goutières syndrome AGS can be misdiagnosed as systemic lupus erythematosus SLE, particularly in children. Both conditions share clinical and immunological features, which can lead to diagnostic confusion, especially in the early stages. Here are some reasons why AGS might be mistaken for SLE. 1. Overlap in clinical features, neurological symptoms. Both AGS and neuropsychiatric lupus, a subtype of SLE, can present with neurological signs like seizures, developmental delays, spasticity, and cognitive impairment. Skin manifestations. AGS may present with chilblain-like lesions, particularly in cold weather, which resemble the skin findings, chilblain lupus, seen in SLE. Systemic inflammation. Both conditions involve immune dysregulation with systemic inflammation. Children with AGS may have elevated inflammatory markers, as seen in SLE. 2. Autoimmune and interferon pathways. AGS is classified as an interferonopathy, characterized by chronic activation of the interferon alpha pathway. Similarly, SLE is associated with type 1 interferon activation, contributing to autoimmunity and tissue damage. Elevated interferon alpha levels in AGS can mimic the immune profile seen in SLE, leading to potential diagnostic confusion. 3. Similar laboratory findings. Blood tests. Children with AGS may show elevated levels of interferon alpha, a feature also seen in SLE patients. Elevated inflammatory markers, such as ESR-CRP, are common to both conditions. Autoantibodies. Although AGS typically does not present with classic SLE autoantibodies, e.g. ANA, anti-dsDNA, the immune dysregulation may resemble autoimmunity, especially if clinical symptoms overlap. 4. Chilblain lupus overlap. AGS is sometimes referred to as familial chilblain lupus, particularly when skin lesions are a prominent feature. This can further blur the lines between the two diagnoses. How to differentiate AGS from SLE? Genetic testing. AGS can be definitively diagnosed through genetic testing for mutations in genes like TREX1, RNase-H2A, RNase2B, and others. In contrast, SLE is diagnosed based on clinical criteria and the presence of specific autoantibodies, ANA, anti-dsDNA. Age of onset. AGS typically presents in infancy or early childhood, while SLE usually manifests later, often in adolescence or adulthood, though pediatric SLE can occur. CSF analysis. In AGS, cerebrospinal fluid often shows elevated interferon alpha acclimation, e.g. neopterin, which are not specific to SLE. Conclusion. AGS can indeed be mistaken for SLE due to overlapping clinical and laboratory features, especially in children. However, genetic testing and careful clinical evaluation, including the age of onset and the nature of skin and neurological symptoms, can help distinguish the two conditions.